Hi, everyone. Welcome to our webinar today, tonight, wherever in the world you are. We are excited to have you. If you don't know me, I'm Claire. I am the research lead at Nerva and Mindset Health. And without further ado, I will introduce Kristina, who is a nurse practitioner at Mass General Hospital in the GI department. Her primary focus is treating patients who have disorders of gut-brain interaction. And while she treats all DGBI, she has an interest in upper GI and swallowing disorders. She's the clinical lead advanced practice practitioner in both the Swallowing, Heartburn, and Esophageal Disease Center and the Neurointestinal and Motility Health Center at MGH. Kristina is also a member of GAP in the Membership Engagement Committee, as well as a member of ACG in the Advanced Practice Provider Committee. So we are very grateful to have her for the next hour. And she's speaking on connecting the dots in DGBI, a patient-centered pathway to understanding, education, and management. So I will hand over to you, Kristina. Thank you so much.
Thank you for having me. This is an honor. And hi, everybody. So I'm going to start off now. I just wanted to show my disclosures, full transparency. So let's get into it. We're going to define disorders of gut-brain interaction. Hopefully by the end of this, you'll be able to demonstrate how to approach your diagnoses with your patient. What do you say to them? How do you talk to them? How do you connect with them and build that rapport? Maybe what kind of testing would you think about? And then identify certain treatment options. So we're going to talk about a lot of different treatment options, including pharmacological and non-pharmacological, because I think both are important. So let's get into our case study. This is a 35-year-old woman. She has a history of anxiety, OCG, hypertension, and obesity. Her BMI is 38. She presents to your clinic and she reports having constipation for her entire life. She says, back when I was a child, my mother would always chase me around with prunes and prune juice to help me have a bowel movement, and to the point where she doesn't even want to look at prunes at this point in her life. So in her late teens, though, her constipation seemed to worsen around that time, and she recalls she was going college viewing outside of her state. And she remembers that she would have hard stools and find herself straining with minimal benefit. She tried psyllium, which is a fiber supplement, and she felt like it made her really full and bloated. And then she also went as far as trying to limit gluten and dairy, and it really didn't do anything for her. So currently, she says that she's had a bowel movement daily, but there are always these small pebble-sized stool. And if anybody knows what the Bristol stool scale is, it's type 1 stool, which means that they're very hard, almost rock-like stools. She sometimes feels bloated, distended after several days of dealing with this stool pattern. And when she can't take it much longer, she goes ahead to her nearest pharmacy, picks up some polyethylene glycol, and she actually takes 3 capsules a day until she results in having explosive diarrhea. And while she's confined to the toilet that day, she says, you know what, I feel the best I've ever felt for my bloating and my lower abdominal cramping. And when you ask her, well, why don't you take it every day? She says she doesn't like the texture. So when we're thinking about our patients, there's questions that we want to ask and that we don't want to miss. She says that she's very interested in trying other treatment options. She's very tearful, and rightfully so. She's like, I feel so bad. I feel bloated, to the point where she's been asked by strangers if she's pregnant, and she's not. And then it sets off her anxiety, and she feels judged and that people are looking at her as being fat. And that's really unfortunate. And we see this, I think everyone can say that they've found patients with similar stories to this. Her vitals, she's a little hypertensive. Pulse was good. Everything else seemed to be good. Her bowel sounds were great. Her abdomen is soft without any palpable masses. She has a mild tenderness in her lower abdomen, but she also says, I think I might have to have a bowel movement soon, so that's probably why I'm tender. You actually go ahead and you do a rectal exam. You don't see any visible masses. Maybe some sentinel piles, which is old, skin tags or hemorrhoids. Perineal descent, which is how well they bear down, was actually within a normal range. Her anal sensation was normal. She has normal anal sphincter squeeze and sphincter tone, which is important. But when she bears down, again, she's exerting minimal pressure. She's got no puborectalis contraction or paradoxical contraction, which is what we're looking for in pelvic floor dysfunction. And her stool is brown and hard. So when we're thinking about looking at her symptoms, we want to ask things like, has she ever had children? What's her obstetric history? When she did have children, was there any need for episiotomy? Was there any tearing? You want to ask her about, does she ever have a history of eating disorders or any type of abuse? Patients aren't going to readily give up that information. So when you ask them, you have to be very cognizant of how you're asking and have to make sure that you're approaching it in a very empathetic way. The other thing we want to make sure about when our history is being taken is alarm symptoms. These are important. You have to make sure these are ruled out. So you're looking at hematochezia, asking about melena, which is tarry black stools, anemia. We all know that that's not normal to be anemic, and there could be multiple reasons why. But from a GI standpoint, we're thinking, could there be a GI bleed of any sort? Unintentional weight loss, they're not eating less, they're not trying to lose weight, they're not exercising as much as or any differently, and they're starting to lose a lot of weight. It makes you think, could there be a malignancy of some sort? Fevers, are they having cramping with fevers, and maybe they have history of diverticulitis? Nocturnal symptoms, they should not be waking up in pain. They should not be waking up losing control of their bowels. And that's very, important that we don't miss that. And then family history of GI cancer should always be in the back of your mind. And with symptom onset after age 50, they shouldn't be coming in with just these random, these types of symptoms after the age of 50. Usually with our patients with functional GI disorders that started years prior. The thing about age 50 is, in our female patients, we're thinking about other pathology, including ovarian pathology. So be very mindful of that stuff. So when we're thinking about objective data, when you're taking your history, you're thinking about, is there a slow transit problem of the colon and moving things along? Is there pelvic floor dysfunction, or is the rectum not sensing stool accurately or pushing it out efficiently? And in that case, you'd want to think about maybe a KUB or a transit study, or an anorectal manometry with balloon expulsion, which usually they should be able to expel the balloon in ideally 2 minutes or less. And when you start to think about those things and maybe there's some, positive or abnormal outcomes, you want to make sure you don't just automatically say, oh, you've got IBS. You got to actually address those points. CT abdomen and pelvis, if you're thinking about any type of malignancy or obstruction or something different. And then, blood labs. If they're anemic, you want to check out a CBC. This is not an exhaustive list, but it's something that we should be thinking about. A TSH, making sure the thyroid isn't acting inappropriately. And then celiac blood serology, so that if they come back positive or potentially positive, you would move on to a duodenal biopsy, which is the gold standard to treat, or a text to make sure that they have celiac or not. But, with IBS-C, you don't really need a ton of testing to get to that. It's looking at things that guidelines, and we'll talk about those guidelines, including Rome 4 criteria. So back to the case, she's, we talked about who she is. She actually says, no, I don't have alarm symptoms, no trauma, no eating disorder. And her testing came back great. And you'd think she'd be happy about that, but we all know she is worried. She says, well, what is going on? Why am I feeling this way? I'm really not feeling good. And she starts to cry and she's frustrated. And she says, you sure you're not missing something? Or, great, you think I'm crazy. My anxiety is making all this happening. Maybe it's my diet. Everyone says my diet, maybe I should lose weight. And you've got to take a step back, listen to those concerns and say, let's talk about this. And we'll talk about how to approach that. So the facts, IBS-C, it affects about 9 to 16% of the general population. I would actually say that sounds really low to me, because maybe it's my biases, because I, deal with patients who have functional GI disorders and IBS-C a lot. And, you always hear people talking about their, maybe I have IBS or my IBS kicked in. So it could be much more than that. It's one of many disorders of gut-brain interaction diagnoses. Mainly women are the ones who get diagnosed with this, but I think it could be in part because men aren't actually coming in to report it or seeking medical care as much as they should. And, a lot of times patients don't come to seek care, or they delay that care because they're so embarrassed. I can tell you, when I'm in an office visit and I ask them, okay, can you tell me about your stool? They look at me like I have like 10 heads, because they like, why do you want to hear about my stool? Even though they know why they're there, and that's why they're, trying to, get some treatment plans. And these patients, they're exhibiting a poor quality of life. They're chained to the toilet. They're worried about where the nearest bathroom is. And, that can be very exhausting over time. And, with IBS-C, you're not going to find a clear pathophysiology, but you have to make sure, again, and I'm going to try and, hit this home, organic disease has to be ruled out. You can reserve a colonoscopy and imaging for alarm symptoms. A lot of times in a setting of IBS-D, if you're working that up, before that, you're going to rule out things like microscopic colitis, collagenous colitis, and irritable bowel disease like Crohn's or colitis. And then imaging, again, we talked about, looking for malignancy, obstruction, etc. So when you're diagnosing a patient with IBS-C, you want to make sure that there's a strong clinician and patient relationship. If they don't feel comfortable with you, they are not going to come back. We've all had, I'm sure, interactions with providers where they didn't make us feel great, and then we're apprehensive to continue to pursue our treatments. Treatment can be made with multiple interventions, but you, during your history taking, want to make sure you base it on their prevalent symptom. And then, you can treat others as well, but focus mainly on their prevalent symptoms. So Rome 4 criteria, I'm sure everybody's heard about this, but this is the way to diagnose IBS-C. And, you can find this, you can go online. There's tons of articles, there's websites, there's social media. We look at things like recurrent abdominal pain. So you want them to be averaging at least once a week or 1 day a week in the last 3 months, and is associated with 2 or more of the following criteria. So it's related to defecation. So symptoms are related to having a bowel movement. They're associated with a change in frequency of stool. Maybe they're not having stooling for, 2 days, 3 days, 5 days. And that's just something that is either been chronic for them and they've dealt with it, or it's become a more problematic issue. Associated with change in form or appearance of stool. I love that Bristol stool scale because it allows me to say, okay, point to what you have been having for bowel movements. They laugh at me, but they are able to, say, okay, well, sometimes it's this, sometimes it's that, and just trying to figure out, okay, well, which is the more common one that you have noticed and is more or is more bothersome to you. So again, criteria should be fulfilled for the last 3 months with symptom onset and at least 6 months prior to diagnoses. Chronic symptoms. So what are disorders of gut-brain interaction? According to the International Foundation for GI Disorders, it's a disorder that generally cannot be diagnosed in a traditional way. So you can't find any blood tests, any, imaging, endoscopic testing to actually say 100% this is IBS-C because I saw this structural reason. When we talk about these diagnoses, we have to find a way to have the patient understand what's truly going on to cause these symptoms. So when I talk about this with patients, this is a great sentence here. Problems occur when nerves or muscles in any portion of the digestive tract do not function in a coordinated fashion. And we consider the sensitivity of the nerves of the intestines or the way in which the brain controls some of these functions as being impaired. So to make this a little bit easier to talk to the patient, you'd say, hey, you know what? Your brain and your gut, they have different types of signals that they send to each other. And oftentimes those signals, they do not match up, or they're, a little bit overpowering each other. So they miscommunicate, and then you have this cycle. And, I try to humanize it a lot when I talk about the colon. I say, the colon, it wants to move things along, but sending a signal to the brain saying, and this is painful. And it just keeps going back and forth, back and forth. This is a really good article. I just wanted to pull it up for you guys. You'll see Douglas Strossman. He is one of the big functional GI disorder pioneers and researchers. He's got a lot of great information about how to approach functional GI disorders, and I just want to make sure that everybody is aware of that this is an opportunity to learn more. So reframing that approach to patient care. It says doctor-centered care. Please, remove that, put it as clinician or, maybe APP, doctor, whoever. But the key here with this type of approach is you want to make sure that the care is centered around the patient. That patient is the one who's going to give you all of that information that you need to move towards an accurate diagnosis through making sure all the different potential diagnoses have been ruled out. So a lot of times, we have to think about, okay, let's go into the office and let's have that patient talk first. We're always so quick. We're running behind and, we don't realize that we may look like we're frazzled after a long clinic day, right? Oftentimes you have to take a step back, walk in, smile and say, hi, can I'm so-and-so, let's talk about this, and let them talk. You want to make sure that they're active in their decision making. You want to talk about psychosocial factors that may or may not be contributing. You want to use communication skills and empathy. That's the key here. You can provide options for treatment, but it's most important that there's a mutual decision between you and the patient, with the patient being the biggest decision maker in their treatment plan. So with the disorders of gut-brain interaction, it's so important that we frame our way of teaching the patient what it is in a positive light. I'm sure you've heard from patients, they come in and they say, oh yeah, my doctor, last time I saw my local person or whatever, said, oh, really, you need to just calm down. Like, it's anxiety. Maybe if you go and do some, yoga or go on a retreat somewhere, then things will get better. And then the patient walks out thinking, wow, what was that? So how we approach it, we have this opportunity to reframe things to help the patient feel like they're being heard, because this is a real disorder. This is not something that's in their head. And so it's important that we say something like, you know what? It seems that your symptoms are consistent with the known disease entity of irritable bowel syndrome. Let's actually discuss this treatment of this disease. Let's discuss how this happens. And we always have to know that structural diagnoses, by default, people are able to accept it or understand it a little bit better than those that are functional, because they can't see the functional reason on the testing like we talked before. And, they always say, somebody thinks I'm crazy. So when we look at disorders of gut-brain interaction, you're looking at it, from all angles, but what we're doing now is there's tons of research still in place. So they're always thinking about, okay, how does this actually occur at other levels? Because it can't just be gut-brain interaction. It got to be something else, right? Or maybe it's not, and we just ruled out other etiologies. So things like motility disturbance, visceral hypersensitivity, altered mucosal and immune function, altered gut microbiota. Patients love to talk about microbiota. And then altered central nervous system processing. So I found this really wonderful table, and it talks about how we approach patients in a way that they can understand their DGBI diagnosis. So 1, you exclude that disease. We talked about that. You use that Rome 4 criteria. They fit it well. Great. You go in, you empathize with the patient. You try to develop a great rapport so that they can say, you know what? Hey, you know what? I saw Kristina today and she really seemed to listen to me. And she said that she was, part of my care team and she really wanted to help me. I actually feel confident that now somebody's listening to me. And then step 3, educate about pathophysiology of that. So we talked a little bit about what that means, the gut-brain interaction and how it functions or poorly functions. And then, other potential causes, which we talked about, that are still being researched. And then step 4, you want to set an expectation. A lot of patients think, you know what, if I just take a pill, it's going to happen right away and things are going to be better and I can go home. This is not like an infection where you take antibiotics and things are great and, that's it. This is something that I say, this is a journey. It's going to take time. I don't even know what's the best approach for you right now. There are options and we'll figure it out. This is a team-based approach. And sometimes what I say to the patient is, you know what? You are the one driving the boat or the car or whatever it is. I'm in the passenger seat just telling you to take a left or a right or whatever that may be. It's up to you to decide which way you want to go, and we'll go from there. And then, also letting them know that it's gonna be, a long journey, but also having them understand it's probably not going to get to 100% improvement. So let's start with maybe 40, 50%. If you want, you can try 30%, and then slowly over time, we can look and see how those trends move upwards or not. And then establish the treatment plan with medications or non-pharmacological modalities. So we talked about excluding organic disease. You guys are going to be so sick of this, and it's going to be in your head by the end of this talk. So obtaining a thorough history, a detailed history, really, we talked about it in others earlier in the presentation with, you want to look at psychiatric history, abuse, history of eating disorder, looking at those alarm symptoms, maybe a history of alcohol or substance abuse. Family history is important, and any type of past medical history, past surgical history, or medications that may or may not be contributing to their diagnoses. Complete physical exam is important. Looking at vitals, abdominal examination. Is it soft? Is it rigid? Do they look like they're super distended? Do you feel any palpable masses? Something not feel right? Do you even hear bowel sounds? The rectal examination can be very important, like we talked about, understanding if there's a pelvic floor issue or not. In this objective part below on the bottom of this slide, I want you to know this is an all-encompassing for DGBIs. I did bold some of the ones that I may or may not use when I'm looking at somebody who has a potential IBS-C diagnosis, but I'm not quite sure yet. And I underlined the pelvic ultrasound because I can't say this enough. You don't want to miss ovarian cancer. It is so easy to do it, and oftentimes goes undiagnosed until it's too late. Try to be mindful of those things, especially if somebody's postmenopausal and they still have their ovaries, or at least one of them. So you're going to educate and empower the patient. Spend time reviewing testing with patients. You did the tests, you bring them in, you pull up those tests, and you say, hey, you told me this. This is what I see on your testing and how it may or may not relate to your symptoms. Patients say, I'm constipated. Maybe they have a ton of stool in their colon. The patients love it. You pull up the x-rays and you say, look, you're very photogenic. You have a lot of stool in there. And they laugh, and it makes them feel a little bit more comfortable. Describe what the DGBI means. Don't use technical or difficult terms. You want the patient to understand it in layman's terms, if possible. You identify those triggers that may or may not contribute to their symptoms. And most importantly, how do they cope? If they've been dealing with this for a long time, I'm sure they have plenty of coping mechanisms. Everywhere they go, they make sure they find a bathroom. Or, maybe they try and make sure they have a bowel movement before they leave the house. So things like that. Allow them time to feel heard, and don't set unrealistic expectations. Don't go in there saying, you know what, if you just do this one thing, you're going to get 100% better and everything will be great, because that's not always the case. So let's talk about different treatment options. I wanted to really talk about all the different types of laxatives. When they come in to see us, they've probably already started with the first three that are listed here. So things like fiber supplements, polyethylene glycol, stimulant laxatives. So fiber supplements, easily accessible. They're supposed to be utilized for bulking and softening of stool. I actually do love to use it in my practice for many reasons, not just for, IBS or things like that. But psyllium is an option, methylcellulose, and calcium polycarbaphyl. Psyllium tends to be a little bit more gassy, bloaty. So I tend to, if that's the predominant symptom, I try to move towards maybe the methylcellulose, calcium polycarbaphyl, or maybe a different laxative or treatment option. Polyethylene glycol, we all know it can come as powder, or it does come as powder. You mix it in 8 ounces of water or liquid of choice. Hopefully it's not something like beer, which counsel your patient on that. But you can give them a capful, or you can do the packets. Packets are really nice for patients because they can bring it and walk around with it and not have to feel like they bring in a whole jug of something, so everybody can ask them questions with something that's already pretty embarrassing for them. It's titratable. I love that. I have patients who are super sensitive and they can only take maybe a tablespoon of it instead of that whole capful, or maybe they can take a quarter or a half packet. Meet that patient where they're at so that they can have the best possible outcome for their treatment. Stimulant laxatives, those things like Senosides, bisacodyl. Bisacodyl tends to be a little bit more or stronger, I should say. Comes as a tablet or a suppository form versus Senosides, which is mostly tablet. Oftentimes we utilize those with combination therapies, so maybe different laxatives as well. Be mindful, it might cause more cramping and bloating, so just be very cautious of that. Linaclotide, now we're getting into the more let's say higher level treatments for moving the bowels. Linaclotide, we've probably seen this very often. It has been approved for treatment of IBS-C. When I first started, it was just dosing at 145 and 290, and sometimes that would be too much for the patient, and we were kind of stuck, and we'd try to figure out other alternatives. They've since come out with a 72 microgram dose, and sometimes that really works for people. It's important you counsel them to take it on an empty stomach, and in addition to improvement in bowel pattern and consistency, it may also help improve pain and bloating in some patients. And then that's the guanylate cyclase agonist. I just want to make sure you have that information as well. So then you have lubiprostone, which is another option. Dosing options include 8 micrograms BID or 24 micrograms BID. Make sure these patients take it with food, else they're going to come back to you saying, why am I so nauseous? And they're not going to want to take it. If somebody already has chronic nausea, you probably won't want to stick with that one as the first choice. I would try something else. And it's a chloride channel activator. And then before I move to the next slide, I just want to make sure it's very important that when you're prescribing things like linaclotide, lubiprostone, or maybe other laxatives, be cautious with patients who've had a history of small bowel obstruction. You don't want to make that worse or provoke one. So, give them those warning signs to think about. And then also be mindful of our child rearing people or childbearing people or people with uteruses that we use things like contraception, especially, or we ask them about pregnancy plans because oftentimes these medications are not approved for pregnancy. And then we have placanatide. It comes as 3 milligrams daily. There's some thought that it can be less of a problem to cause diarrhea for patients, so maybe patients said, I've tried the linaclotide, I've tried the lubiprostone, I am like having tons of diarrhea. And while I'm very happy to have those bowel movements, it's become a lot. So maybe you move on to that placanatide dose and they start to feel, okay, this is a little bit more tolerable for me. It comes as a tablet. You don't have to time it necessarily to morning meals, etc. And again, it's a different type of guanylate cyclase agonist. Tenapanor is another one. It comes as a 50 milligram capsule or tablet. Take it twice daily. It can help with bloating and pain, or at least that's what they're starting to see through research. But it's important that we counsel the patient that they probably won't see the full effect for about 9 weeks. And that can be hard. That can be very challenging for patients, especially when they're so eager to get things moving and feeling better. So let's move on to antispasmodics. Those patients that say, oh my gosh, that cramping is horrendous. I can't stand it. It knocks me out. Or, I feel so tired afterwards. So I actually don't use them that much. And, I use other methods for pain control, etc. But if you want something that's very quick acting, these are definitely some options that you can utilize. So dicyclamine comes as 10 milligrams. I usually recommend around BID dosing as needed. You want to use the lowest dose available because, it can cause dry mouth, drowsiness, etc. And I really want to hit home, you got to be cautious with older adults. You don't want them to, start to get sick or dehydrated or fall because they're so drowsy. Same thing with hyoscyamine. It actually is a sublingual medication, unlike the dicyclamine. And they can take that up to 3 times a day as needed. And it blocks the action of that acetylcholine at parasympathetic sites. And again, same thing, short-term relief. There is an extended release. I actually don't use that as much in my practice because patients want that quick relief, and rightfully so. And again, you want to use sparingly because these antispasmodics, they can actually worsen constipation. So you got to figure out which one you want to actually, address and what you think you can, or what the patient can actually tolerate. And then some patients have already tried it before they come to see you, but enteric-coated peppermint oil can be very helpful. There's theory that it can be anti-inflammatory or a muscle relaxant. It's used for abdominal pain, as we're talking about, and it's pretty well tolerated. So neuromodulation options. I have to say, this is one of the most challenging things as a GI provider when you're going in and you're telling the patient, hey, yeah, I don't think you're crazy. Yours is a very real entity, but let me give you something that's often used for mental health issues. How can you try and rationalize that with the patient? I hope by the end of this talk you can do that. But these are the different options we'll go over today. We'll talk about why we would utilize them, and as well as the dosing approaches that you might want to try. And again, I'm trying to make sure that I give you the full list. It doesn't necessarily mean that you're going to utilize this for our particular patient. So central neuromodulators, oftentimes while the patient, you're trying to educate them, we often have to educate our own, right? We have to educate our clinicians that we work with. Hey, you know what? Let's talk about how we would dose this. A lot of people, when they start off in GI, they're very hesitant to utilize these medications. And a lot of times, people will utilize the TCAs or the tricyclic antidepressants and then stop it at a low dose and say, all right, I don't want to go any further with treatment because they don't feel comfortable with that. And I really want to make sure that we reduce the stigma that comes with these medications, stigma from clinicians and also the patients themselves. So it's really important that we, help each other out and discuss, these situations and potential treatment plans with each other and the patients as well. So how do we do this? How do we talk about this with patients? I love this article. It's great. It helps with talking about shared decision making and how you should really approach the patient. So before we get into that, I do want to say how you're walking to the visit, we touched upon that before, is so important. So that first impression, that's really important. People start to judge after a few seconds of knowing you, right? So when you go in there, you don't want to be frazzled. You don't want to be, in a state of, distress or whatever it may be. Make sure you ate lunch. I know that's difficult for us clinicians, but invest in that first impression. Give some eye contact, smile, say, hi, you know what? Introduce yourself. I am so-and-so, and I'm here to talk to you about your symptoms and hopefully get a treatment plan that works for you. Give them that time to actually talk then. They give you their whole story. Sometimes patients come in with stacks of information. Try to get them to, really just talk about the most important aspects as best as they can, and try to let them talk for at least 1 to 2 minutes without interrupting them. You don't want to be sitting there just typing away, looking at the computer, because then it looks like you're not listening to them at all. Acknowledge when they become emotional. They're dealing with something that's embarrassing. They're dealing with something that it impairs their quality of life. Maybe something that is very painful for them. So when they start to cry or they start to get angry, acknowledge that and say, this looks like it really bothers you. And then, it allows for more dialogue. There is a note about touch. I want to be just a little cautious with that. There is a disclaimer there. If a patient has a history of abuse or trauma, you want to be sure that you understand that before you start using therapeutic touch. But when you do a physical examination, hi, can I do this physical examination for you? Is it okay that I feel your belly? Let me know what hurts. For my patients with, autism spectrum disorder or developmental delays, I oftentimes will say, hey, put your hand on mine and let's do this together. And that makes them feel a little bit better too. Empathize with the patient. Understand that this person's experience is real. Try to think about how they have to deal with this every day, and then try to, empathize. So, something like this, being sick while going through a divorce, that must have been really difficult, and you're doing your best to cope. Or maybe, it's really sad. I understand that you are missing your mother who you lost. Let's talk about how to cope with that and go forward. So develop your script. Let's go to how do we talk about choice talk. So you want to take a step back and you say things again. Now that we've shown that your testing has ruled out organic cause, let's talk about how we should move forward with treatment options. There's several recommended options that we can use to treat your persistent GI symptoms. Be cautious with certain cultures. They don't want to make the first choice or decision. So be mindful of that as best as you can. Look for social and non-verbal cues. When you're trying to think about justifying choice, you say, hey, there's benefits and downsides to different treatment options. I'm not sure which one will work best for you. I tell this to patients all the time because they say, okay, what dose do we need to get to so I can feel better already? And I say, listen, I don't know, actually. Everybody's body is different with how they, tolerate medications, the doses that work for them, etc. So let's see how things go. And this is where, you keep in touch with me and let me know how your treatment plan is. And we can adjust on the portal or through frequent follow-up as best as we can. Check reactions. Seems like you're not too excited about this. So they're looking at you like, what are you talking about? Why are we doing this? So you take a step back and say, okay, let's talk about why. A lot of times when we're busy, we'll forget to talk about the why, right? We'll say, oh yeah, you need to try this, or you need to try that. Talk about why this is going to help the patient, or what you anticipate the patient will benefit from. And, read the room, right? If the patient is shutting down, you need to make sure that you are aware of that and try to, move them into a direction of looking at the positive and how to, develop their treatment plan with your assistance. Option talk is so important in building a therapeutic rapport. So when you're thinking about a patient, you're talking about that or to them, you would say something like, do you know the different ways that we utilize treatment plans for IBS-C? Have you already researched it? A lot of times patients already say, I want to try this medicine, or I want to do this. I'm not really interested in medications. I'm not a medication person. Let's try something else. And let them have that opportunity to discuss that. And then if they don't have any concerns, or they want to hear more about other options, you can say, let me list those options that exist. And, it's up to you if you want to choose them. I'm not going to push you either way. And I find it very useful to do that because, it allows the patient to feel like they're part of the conversation. So, and when you're describing options, you can say, well, we can try these traditional laxatives or neuromodulation, or we can even go the complementary alternative approach if you'd like. So it gives them that broad choice of options. Be upfront about those harms and benefits that could happen. Don't keep that tucked away somewhere. They should be mindful and cognizant that, maybe this medication has more risk of maybe serotonin syndrome and things like that. Ask patients to try their medications consistently. A lot of times they take that first dose, the 2 weeks or 3 weeks has gone by, and then they stop the medication, come back to see you in 3 months, and they say, oh, it didn't work. Okay, well, this is where you can say, let's talk about doing this as a team-wise approach. So I have a nurse. I'm very lucky to have a triage nurse that I can count on to hear patient concerns in between visits. And they often will talk to me and then maybe other providers in the care team, like the physician, and say, I've been taking linaclotide for 2 weeks, and I've noticed A, B, and C. And then based on what they tell you, you can slowly titrate in between, whatever way you want to go, lower, higher. And it allows them to have a little bit of a, ongoing treatment change before their 3-month follow-up. Decision talk, it solidifies that therapeutic alliance or rapport. So, when you're talking about preference, you say things like, it must be frustrating. Utilize that word. It must be frustrating to be told that your testing is normal and that you're still suffering symptoms. What do you want to achieve with your IBS-C? What is that predominant symptom that's really holding you back? What's your goal for today's visit? Because patients often already have a goal, or maybe they have thoughts already of what they want to do. They just never had the chance to actually bring that up. Elicit a preference. So now that we described different options, which do you think is actually aligned with the goals that you want to achieve at the visit? A lot of times patients say, I am not a medication person. I'm super sensitive to them. I hate it because every time I go to doctor's offices, they always want to throw pills at me. You say, okay, let's think about other options. Maybe there's supplements. Maybe there's complementary alternative medicine. And we'll talk about what other options we can utilize with those later on. It's very rare that I can say, or that I have said, there's nothing more I can do. Try to exhaust all options. These patients appreciate it. And that's just really important to remember. So we talked about, following up on the portal. I mean, it does contribute to provider burnout, but it does help the patient not feel like they're stranded in between visits. So let's talk about neuromodulation. Tricyclic antidepressants are very, very commonly used, in the community as well as in tertiary quaternary medical centers. We tend to use doses between 10 to 150 milligrams. I would say I usually go to 100 milligrams. A liquid formulation in certain medications and certain tricyclics can be utilized. It's used for things like IBS, centrally mediated abdominal pain symptoms, functional chest pain. I've used it for cyclic vomiting syndrome. It's more effective in reducing pain than serotonin reuptake inhibitors. Amitriptyline and imipramine are very commonly used in the community, but are definitely more potent. Nortriptyline and diazepam are generally less potent, and nortriptyline, I like it because I can actually use liquid doses to go even lower for my sensitive patients. So, maybe they can't tolerate that 10 milligrams initially. Maybe we draw it back to 10 or 2 milligrams and slowly increase over time to build that therapeutic response. Side effects include dry mouth, constipation, and dry eye. I sometimes check it, or often I will check an EKG to look for QTC prolongation, especially if it's going to interact or potentially cause QTC prolongation with other medications that they may be taking. You want to be very cautious with patients who are over the age of 65, so not to dry them up like we talked about with other things like antispasmodics. And a lot of times they have it helps with sleep. It is a medication that does make you very drowsy, and you should take it at night. When you're thinking about what time to take it at night, a lot of times patients, when they say, "Oh, I wake up really groggy," well, what time are you taking it? Well, I take it at 11. I go to bed at 1 a.m. and then I wake up at 7. Well, of course you're going to be groggy. Let's take it, pull it back, maybe take it at 8 or 9 so that you can have a better time sleeping throughout the night. And this is just something for you to look at. We talked about dosing already. So SSRIs, or selective serotonin reuptake inhibitors, they're not first-line therapy for painful functional GI disorders or DGBIs, but it may help with patients who have functional chest pain. They may be useful for people who maybe also have anxiety, or hypervigilance about their symptoms. But it's important you say, listen, I'm not a psychiatrist. I'm not treating you for those things. I'm just saying it may help those things. IBS-C treatment of pain it's not the main symptoms. You might want to utilize it to cause diarrhea. That can sometimes be a side effect of these medications. I listed all the different options here. We've, sertraline, citalopram, escitalopram. I tend to, in my clinic, utilize the better tolerated ones, which is citalopram or escitalopram. There's also other options like fluoxetine, paroxetine, but there are interactions that you must be aware of before you think about that. I have to say I do have close collaboration with a psychiatrist, only because I, know that this is more in their wheelhouse. So I want to make sure I don't interfere with things that they may be taking, or maybe other mental health diagnoses that may or may not be well controlled. Make sure you take these medications with food. Don't stop them abruptly. They should be tapered. Counsel on delayed benefit and response. It's not going to happen overnight. Avoid NSAIDs to avoid any GI bleeds. And here again is some options that we talked about in their doses. Serotonin and norepinephrine reuptake inhibitors, SNRIs. Off-label use for visceral pain. So somebody who has functional abdominal pain syndrome, it can be very helpful. I often look at the patient holistically. So if they've had other diagnoses like diabetic neuropathy, the big one, fibromyalgia, or chronic pain syndromes, it might be a nice, medication to treat everything. Again, making sure the patient understands you're only treating their functional GI disorders, but if it helps other things, great. It's less constipating than TCAs. Again, better pain control than SSRIs. You should probably take it with food because it can cause nausea. And there's things like the options that we usually utilize are things like duloxetine, venlafaxine, midazolam. And the doses are listed here. Duloxetine, I've actually started a patient off at 20 milligrams, especially if they're super sensitive. So be creative. Try to make sure you give the best chance at these medications as you can. Then you get atypical antipsychotics. I really don't like how this is the class of medications and how we name them, because it doesn't sound very good when you're presenting it to the patient, especially when you're telling them that you believe that things are real, because you do, and that you don't think that they're crazy. But it's often second line in treating disorders of gut-brain interactions. Second generations like olanzapine I've utilized in the past, especially if patients have nausea that could be related to functional GI disorders. You want to be aware of dystonic reactions and Parkinsonism. I really, really strongly encourage that if you're going to think about this, they already consult with a psychiatrist first to make sure it's safe. And here's the medications and doses listed here. And then you got miscellaneous. So buspirone is another medication. Generally, you can utilize it for things like functional dyspepsia to help improve gastric compliance and accommodation for food, etc. And, it often has been prescribed for anti-anxiety. So again, it could be one of those things where if the patient has anxiety and then also has functional dyspepsia, you might be able to treat both. But again, looking at just, I'm only treating at the functional dyspepsia part. Trazodone is another option. It is similar to TCAs in the sense that it could be a cousin of them. It does cause drowsiness, and it can oftentimes you'll see these patients are utilizing it for insomnia and help them get to sleep at night. But I've utilized it for things like functional chest pain in the past. Mirtazapine is another great option. It can be utilized for nausea, weight loss, dyspepsia, gastroparesis, may help with insomnia. Again, you have to take them at night to avoid any drowsiness anytime these medications are nighttime medications, make sure you counsel them, hey, you take it, you don't use any heavy machinery or do anything, drastic that may be harmful for you. It's less likely to cause sexual dysfunction. And just so you know, with that medication, I tend to start at like 15 milligrams. I can even go as low as 7.5. I've even, with super sensitive patients, have used 3.75 milligrams and slowly uptitrated as tolerated. Delta ligands is one of the other ones that we utilize. The thing about them is I actually really like the fact that they're considered gut neutral. They're not going to cause constipation or diarrhea. It can potentially increase distension sensory thresholds in IBS patients, especially if they have rectal hypersensitivity. And then some studies suggest there could be improvement in gastric accommodation. Gabapentin can be prescribed in liquid dosing, so that can be super helpful for our very sensitive patients who can't automatically go into a 100 milligram capsule, which is the lowest capsule dose that we can get right now. And I've up-titrated as high as 900 milligrams TID. Sometimes I've even gone with adding maybe 1,000 milligrams at night instead and keeping the morning and midday doses 900 milligrams. Side effects are very important. I've seen weight gain. I've seen peripheral edema, especially with pregabalin. I've seen, sedation. So make sure the patient knows to call you if any of those symptoms occur and then stopping the medication. And then, other medications that I don't typically use, but I've seen others use, is bupropion or topiramate. Maybe somebody is, hoping to also lose weight, but be mindful it could cause nausea. Topiramate, I've actually seen patients develop kidney stones. And I was shocked when it started, I saw that happen. And I looked it up and I was like, wow, it really does. And, now I'm very, very mindful. If someone has a history, I am not using it. And here's the medications listed here. And you'll see the doses that I talked about with mirtazapine. There is 7.5, but you can be really creative and cut it even lower. So when you're prescribing these medications or neuromodulator agents for DGBIs, you got to monitor for all those other things like depression, SI, suicidal, homicidal ideation, mania symptoms, hypomania. Counsel the patient. Hey, if you notice that you're rapidly, talking or have like impulsivity, you're not sleeping at night, you need to give me a call and we need to think about tapering you off or stopping the medication. Serotonin syndrome, very, very important, very, recognized as a concern in some of these medications. And they're listed here: fever, muscle rigidity, tremors, confusion, tachycardia, etc. So, they come in, you've talked about certain medications like laxatives, stimulant, or I should say antispasmodics, and then neuromodulation. And they say, oh my gosh, that's a lot. What do I do? And you say, well, hold on. Let's talk about this, because I don't think that you necessarily just need a medication. You can actually find better benefit with this three-legged stool approach. So three-legged stool, you have the three legs, that stool is going to stay firm and tall. Sometimes if you don't have all three of those legs there, things aren't going to be adequately treated. So you might want to say to them, hey, you know what, we'll try medications, but why don't you go ahead and try the complementary alternative medicine? Maybe you should think about, GI-directed behavioral therapies. And patients love that, and they actually find that they are more actively involved and also, moving in the right direction. I understand that not everybody has these resources, so it's important to, look for other alternatives. So we'll talk about maybe other ideas of trying to get that GI-directed behavioral therapy. I can tell you I work in a tertiary center, and that's not easily accessible to me as well. But again, there's a lot of options. Don't just say like I'll try this one thing and then send them on their way. Give them a real try to get better. So treating DGBIs with complementary and alternative medicine. Believe it or not, I actually have a ton of patients that love to hear about these options, and they actually feel like they're being heard when you're not just throwing the pills at them, right? There's not a great amount of evidence for some of them, but if it doesn't hurt them and it makes them feel better, go ahead, do it. And it doesn't interact with other things, go ahead. So you want to keep an open mind. You can't go in there saying like, oh my gosh, all this voodoo talk. No, it's not. It's actually very helpful, and it's been, something that, patients like. And we're going to continue to research how that is helping them and why. So, listed here for nausea and vomiting, ginger, cannabis. I know that's taboo, but it's been very helpful for patients. And if you can find somebody who actually knows the mechanisms and can help assist you with that as a treatment option, go for it. Acupuncture, patients love that. Relaxation therapy, Reiki, awesome opportunities to, make them, just be in the moment. And it helps as adjunct therapy. Dyspepsia, complementary medicine. There's certain foods that might be helpful. We talked about peppermint. Iberogast is another one. And then diaphragmatic breathing for bloating. We actually treat our bloating and one of the treatments is diaphragmatic breathing, where we have advanced practice providers actually teach the mechanism of how to strengthen the diaphragm to help them eventually with things like bloating, belching, things like, and sometimes even nausea. And then for IBS, psyllium, prebiotics, probiotics, there's not a whole lot of data on that with patients with IBS-C, maybe more so with IBS-D. Cannabis is another one, aloe vera. A lot of times patients have already tried that before they come to see me. Turmeric is another one that they may have tried. And then CBT, hypnotherapy, and even physical activity. Go out and take a walk. Very helpful, very relaxing, as long as you're not in a big, heavy traffic place. So, GI-directed behavioral therapy can actually be very, very helpful for patients, especially cognitive behavioral therapies, gut hypnotherapy. There are trained professionals that really know how to do this appropriately and in a safe environment. You do not want them to just do this, with somebody who doesn't have the experience on how to do them. You don't want to awaken traumas, etc. So, and oftentimes, when other providers who may not understand how helpful these things are, they might say, oh man, and they should really go just see a therapist and figure it out. And that's not true, Patients can also say, oh great, so you do think I'm crazy. It's not. And you have to counsel them on how, it has been helpful and that it's not just the only treatment that we're offering. It can address comorbid depression and anxiety conditions, but also can reduce symptom-specific anxiety. These patients, because they've been dealing with it for so long, it's in their head all the time, and they think, oh my gosh, all the time. What am I going to do with this? And what are CBTs? And again, it's using psychotherapy to address its cycle of thought, feelings, and behaviors. So here we are with CBT with technology. I'm sure you guys are well aware of this. I have no idea why you're at this talk, because we have Nerva who sent all this information out. But, cognitive behavioral therapy, I understand not everybody has those opportunities to connect with those who are trained professionals. So this is a great option for patients, and it might even give them the opportunity to be in a safe environment, do things at their leisure, and allow them to kind of feel like, I can do this on my own, and I don't need to involve, somebody else, or maybe I can do it in private so I don't feel as embarrassed. There's videos, there's articles, there's progress tracking, and just to take a step back, patients are feeling embarrassed with certain things. So maybe they don't want to do this in a group setting, or maybe they don't want to do this in a public area. So being in their home, they feel much safer. I can tell you, even today, every patient that I see, when I ask them about their bowels, or their GI symptoms, they're embarrassed, especially, if there's fecal incontinence. You have to pry that information out of them because they don't want to bring that up. They're embarrassed of it. Who does that? Actually, a lot of people. There's a lot of people, and I tell them that there are a lot of people with similar symptoms than you. Spend a week in my clinic and you will see. And then they go, oh, okay, all right. And they start to feel better. And, I just want to make a quick plug for things like acupuncture, Reiki. Sound bath therapy is a newer option, which can invoke a relaxation response, and then Tai Chi. And I don't want to forget diet therapy, because we all know the patients come in and they love to talk about their diet. But I also say to them, it's not just diet. There could be a component of diet. But I also want you to realize that just because you're eating certain foods doesn't mean that you're provoking those symptoms. But the options that they may or may not have tried are things like FODMAP diet, gluten-free, lactose-free diets. A big one is limiting cruciferous or gas-promoting foods like beans or lentils. But you have to be mindful when these patients are doing these diet changes. You want to make sure that they don't have a history of eating disorders. You don't want to provoke those symptoms or make them come back. And then one of the big things I see is something called avoidant restrictive feeding intake disorder. You want to make sure that they don't fall down that rabbit hole of just restrict, 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 so they're left with nothing but maybe bland chicken. So in that situation, when you're thinking about dietary therapy, you want to make sure a dietitian is involved and their primary care is involved, etc. So let's go back to our case study. I know it sounds very like we've been talking forever. So you spent 45 minutes with her discussing her diagnosis, her treatment options, and through shared decision-making, she says, you know what, I'm going to try linaclotide, 145 micrograms. I think I can tolerate that every morning on an empty stomach. I have no plans for pregnancy. I don't have a history of small bowel obstruction, and I'm cool with trying it. So you say, okay, send me a MyChart message in a couple weeks. Let me know how things are going. Obviously sooner if you have a problem. And she does. And she says, you know what? My stools, they've gone from a type 1 pebble-like stool to now type 3 or type 4. And my bloating is actually improved by 80%. But she says, you know what? I still have that cramping before defecation. And that's kind of annoying. And it's not pleasant. So after discussion again, you follow up is that you say, hey, let's think about other options. And that's when you, after discussion and just shared decision making, you decide to try duloxetine. And you start at the 20 milligrams or 30, whatever you feel comfortable with. And then eventually over time, you are able to increase the dose to 60 milligrams. And while that's not a high dose, it has been very helpful for her, because after 10 weeks, she says, you know what, my cramping is now 85% controlled. And she says, you know what, I also started practicing yoga, and I'm using the Nerva application for gut hypnotherapy. And she's very pleased and thanks you for helping her. So let's wrap this up, because I know everybody is eager to eat dinner or go about their day wherever they're located. DGBIs or functional GI disorders are real. They're not fake. They are not crazy diagnoses. These are very real symptoms that people deal with every day, and they really make a lot of challenges in their life. Choose a bowel regimen that works for the patient. It might not be the first choice that works, and that's very common. Don't get discouraged. Neuromodulation are options to target symptoms. We all can reduce that stigma of utilizing these medications. And I gave you a whole list of things, but try to familiarize with maybe 2 or 3 that you're comfortable with and build upon it over time. And again, utilize your resources. So if there's psychiatrists you can reach out to, or, it's very important that you do, especially with certain patient populations that may or may not have other medical comorbidities. Just develop your script. How do you talk to the patient? Make sure you develop a way to connect with the patient. We've given you plenty of tools with that. Collaborate with all your providers, your APP, your RN, your dietitian, your psychologist. All of those people are part of the team. And all of those people help their patient get to the goal, right? So we talked about the nurse helping out with, checking in with the patient. We talked about the AVP spending 45 minutes with the patient. The doctor comes in and also spends time 45 minutes with the patient, whatever the case may be. Everybody is part of the team, and it takes a village to take care of patients. And that's why we do it, right? We want to help people. And then utilize your options, pharmacology, CAM, behavioral therapies. Remember that three-legged stool approach. And it's okay if you can't do the full three-legged stool. Do your best. And, that's all the patients can ask for. Thank you.
Thank you so much. We are just about out of time, but we might have time for one question if you're open to it. I'm a dietitian specialized in eating disorders. This work around DGBI is so important to our field because obviously elimination diets are typically contraindicated for my patients. Because of this, many of my patients get turned off from seeing GI docs and instead try to manage their symptoms on their own with their primary care provider. What should I be looking for in a GI practitioner when I work to make referrals for my patients? My patients rarely see GI specialists who go this deep and are this knowledgeable in options for treating DGBI.
Awesome question. And I totally understand your, concerns and frustrations for the patient, right? A lot of times, working in a motility center or a neurointestinal health center, you have more resources for the patient. We see them all day, every day, these types of diagnoses. We know how to manage them. And if we don't, we collaborate with each other. I mean, we do a lot of research on these, and it's ongoing. So I would say try to find your nearest motility or neurointestinal health center. And, like I said, it takes a village. Utilize the village as much as you can. And understand that you might not be able to get all of the people together, but even some can be very helpful.
Awesome. All right. I just want to say thank you so much, Kristina. That was really wonderful and is really such a great resource for our providers in managing these patients who, like you said, need all the help they can get and all the collaboration. So we really appreciate your time.